Good evening, friends. Welcome you into this episode of Journal Club discussion by GICS.
Sir, we'll just wait for 2 minutes.
Okay.
I think you give countdown for Anirban to start off with. Vinay.
Yes, you can give countdown.
Maybe we wait for about 50 people at least to join, sir. Now it's about 23.
Yeah.
Recording in progress.
Is it audible for all others?
दे दो.
Hi, Pradeep.
Hi, who's this?
Sorry, just stuck in
Oh,
traffic.
Justin, yeah.
Justin. Hi, Justin. Hi. Where are you, Justin?
Ajit.
Yeah.
Pradeep.
Hi. I can hear you.
Hi.
Farooq,
Hi, Farooq.
Good
Hi, Vasas.
Good evening, Anirban. Da. How are you?
Anirban, Dada, good evening.
Can Anirban start, Vinay?
Yes, sir.
Anirban, you can start off. Anirban?
I think he's muted.
Anirban, you're muted.
Good evening, Dr. Guru Prasad. I think neurologist from Yeshwanthpur, isn't it?
Yes, Raja.
Yeah.
Akka, our doctor, husband of
Radha.
HRO.
Radha's you.
Good evening, sir. Please welcome.
Anirban, are you there? Anirban is muted. Ajit, one of you can call him up.
He is unable to connect, I believe.
Okay, maybe Ajit, you can start off then. Maybe in 2 minutes, maybe
Yeah.
6:50, maybe. If it hits.
Okay. So he want to be allowed to enter. Yeah. Vinay, can you just do that?
Sir,
We'll do it.
Okay, 50 is reached. We can possibly connect, no? Raja?
Yes, sir, we can start now, sir.
And Anirban, we're just waiting for Anirban to get. Ajit, if Anirban is finding difficult, you can start off, Ajit bhai.
Well, is it fine?
Yeah.
Yeah.
We can hear you,
Now it's
Anirban.
audible, sir.
Is it fine?
Yes.
Yeah.
You can start off.
Yeah. Good evening, friends. Sorry for this inadvertent delay. We welcome you all in this first session of the very important journal club, the GICS Journal Club. And today in this GICS Journal Club, we are discussing one of the recent studies which has gained worldwide attention. And before we go, we will just give a brief idea that tenecteplase and alteplase are not new drugs. They have been used for a lot of times in acute cerebrovascular ischemic episodes as a thrombolysis. But this drug has again a non-inferiority trial in addition to a lot of other studies which have come up. This is an additional which was published in February in Lancet. And without going any further elaboration, I will move on to Dr. Pradeep Rangappa. Dr. Pradeep is Senior Consultant Critical Care at Manipal Hospital, Yeshwanthpur. I welcome Pradeep to present this very important journal club, the Trace 2 trial. And we also have amongst us as elite panelists Dr. Ajit AK from Aster Hospital, the lead intensivist. And we also have Dr. Guru Prasad, one of the leading neurologists from Manipal Group of Hospitals to discuss. But finally, before we discuss, we move on to Dr. Pradeep to present the this this on the journal club this study. Yes, Dr. Pradeep.
Yeah, thank you, Anirban, for the good introduction, and thank you, friends, for logging into this journal. So this will be a quick journal review. So we intend to do this every week to take you through some of the latest nuances about any new practice-changing articles that have come. The reason I picked up this trace to trial is, although on the face of it, for all the trainees, you look at it, you would think that this is a non-inferiority. Anyway, we knew that tenecteplase is as good. So, but there are a lot of caveats. I think the beauty about reading the full text of the article is we get to understand so much of nuances in these articles that will put us a lot of queries as to whether we can take it on the face value about the conclusions or should we deliberate more. So this is what we are here for to discuss. So this was a trial, tenecteplase versus alteplase in acute ischemic cerebrovascular events, came published on 9th February 2023. It's an open label randomized controlled trial. So the whole question is comparing tenecteplase versus alteplase. So far until now, we knew that alteplase was the standard of care. And the thing about alteplase was it had to be given as a bolus, around 10% is given as a bolus, and then as an infusion over an hour. So the distinct advantage of tenecteplase is it is given as a stat dose without the need for infusion and without splitting the dose. So that was the distinct advantage. And to see if tenecteplase is non-inferior to alteplase. So there was a trial prior to this also. This is not the first one. So this was a trial which is a registry linked trial. It's a ACT trial which compared tenecteplase 0.25 mg per kg versus alteplase 0.9. So these doses are considered standard at this point of time, 0.25 mg per kg and 0.9 mg per kg of alteplase. And this ACT trial, which was a registry link, it was not a randomized, and the number in this study was around 1,577 patients. So as many as the numbers that were included in this particular trial. And it was shown that tenecteplase was non-inferior with 90-day functional outcome, and the safety also, it was non-inferior to alteplase. So this also came in 2022 by Canadian authors, and it came in Lancet. So this possibly paved the pathway for these further randomized controlled trials to see whether this is good enough. But the concern we had prior to this is about the dosing. So when you talk about alteplase dosing, so the first trial that came was by the European trial called the SITS-MOST trial. So there was an argument whether 0.9 mg per kg was good enough at that point of time, whether the lesser dose is what would be more applicable for Asian population. Then, in fact, the study that came for the Asian population was this Indian study, which came in International Journal of Stroke in 2014, which showed that the 0.9 mg per kg of alteplase is safe and effective. So the reason we are talking about this is even the dosing for thrombolysis, there are trials to see whether the dosing has to be different for different populations. So what was agreed upon is even the Asian population or the Caucasian population, the dosage remains the same. The reason why we are talking is they looked at the safety dosages in the TRACE 1 trial. Then this Enchanted trial came. So this Enchanted trial basically was an Australasian and Chinese trial, which looked at 0.6 mg per kg of alteplase to see whether this has the same effect of 0.9 mg per kg, and they found it to be inferior. It did not meet non-inferiority. So which was a negative trial which said 0.9 mg is what is the standard dose and the lesser dosage was inferior. So this is what came out in Enchanted study. So now the agreement is 0.9 mg per kg is the standard for either Caucasian or for the Asian population. So TRACE 1, which is a phase 2 randomized controlled trial, was to look at safety and the dosing of this alteplase and the tenecteplase. So here they found that the tenecteplase that was used at 0.25 mg per kg had a similar safety as that of alteplase, 0.9 mg per kg. So TRACE 1 was mainly to look at the safety of the dosage of tenecteplase. I will show you two trials which has looked at various dosage of tenecteplase. So the TRACE 2 trial, the question was whether tenecteplase is non-inferior in patients with stroke who are eligible for IV thrombolysis, but who are ineligible for endovascular thrombectomy. So this is a very important exclusion they made. So they excluded patients who are not eligible for endovascular thrombectomy. So who are not eligible were taken. So it was a multicentric, prospective, open-label, randomized control trial. 53 ICUs across the China, 1:1 randomization, and tenecteplase was used at 0.25 mg per kg and alteplase as a standard 0.9 mg per kg. But the maximum dosage that was used for tenecteplase was 25 mg. So which means you have a 100 kg, you would give 25. If a person weighs more than 100 kg also, you would give only 25 mg. You wouldn't exceed the dose. And alteplase also 90 mg. Very easy to remember. For 100 kg, you can go up to 90, but not more than that. So this was the dosing they had. So they had to institute treatment within 4.5 hours, and modified Rankin score had to be less than 1. Just little pay attention. We can have a discussion on this. So they took someone with less disability. Just for our trainees' benefit, this is the modified Rankin score. So 0, 1 means where there are no symptoms or no significant disability. So they took patients who had very minimal disability, and National Institute of Health NIHSS score, they took between 5 and 25. So this was the inclusion criteria they took. So another thing they did was the clinician who were doing the trial were masked to the type of treatment. So obviously they were blinded whether the patients got alteplase or tenecteplase, but they were not blinded to the randomization process, in the sense which one will go to which group was not masked. So this could have possibly infused some bias into this, which authors do submit in their limitations of the study, because they were not blinded for the population stratification that they did. So which means there could have been a potential bias. So the primary outcome of this study, which is important, is to look at modified Rankin score of 0 to 1, which is no disability or very minor disability at 90 days. But when they enrolled the patient also, they should not have had a major disability. And the safety outcome was to look at intracranial hemorrhage within 36 hours. So this was the outcomes they looked at. So 1,430 patients were recruited based on the power. So as I said, the Act 2 trial had around 1,577. So the recruited patients between 12 Jan 2021 to 29 May 2022. So when you look cursorily at the results, the primary outcome which they looked at disability or the modified Rankin score of 0 to 1, which is no disability or minor disability. As you see, there was statistically no difference between tenecteplase and alteplase. But look at the numerical value: symptomatic intracranial hemorrhage less than 36 hours. It was 15 in tenecteplase and 13 in alteplase. Again, did not attain statistical significance. As you see, confidence interval, no statistical significance. When you look at mortality, numerically, mortality appeared more in tenecteplase, 46, and 35 in alteplase. Again, did not attain statistical. So this is on the face of the trial. If you only read an abstract, this is what you will see. And one would ponder, this is as good as it. But when you dwell deeper, this is what you would see. So this is the baseline characteristics, like any other good randomized controlled trial, no major differences in any of the thing. I have just highlighted the cost of tenecteplase in China. As you see, the cost of tenecteplase was more as compared to the alteplase. So we will look into the costing when it comes to our country. And this is all the table of all the modified Rankin score at various intervals they have looked at. And as you see, there is no difference between tenecteplase and alteplase. You can see the right hand p-value. There's nothing that is significant. Equally matched with baseline characteristics. No difference in any of the modified Rankin score at various time intervals. And this is again, as you see, most of the patients fall between light blue, which is the modified Rankin score of 0 to 1. Most of these patients fall in this, and it did not show any difference between alteplase and tenecteplase group. And forest plot, if you look at, they have stratified and done subgroup, whether in males there was any difference between alteplase or tenecteplase, whether in some of the patients who underwent for bridging thrombectomy, whether there was any difference, because some of them were taken up, which I will show you in the table. And age-wise stratification also, there was no difference between tenecteplase. They have stratified between 18 to 59, 60 to 79, more than 80, and they've looked at different NIHSS score. So as you see, you can see the right-hand side, none of the p-values are significant between the alteplase and tenecteplase. So basically, in the subgroup analysis of all the stratified groups, you see there is no difference between tenecteplase. But this table, just have a look, because if you read the full text of the manuscript very carefully, nowhere do authors mention about this aspect, which is the intracranial hemorrhage, which happened within 36 hours. If you look at the tenecteplase group, had 10, as opposed to alteplase, which is 3. And this is the beauty of reading the full text of a manuscript, and it almost attains statistical significance. So this is very conveniently ignored in any of the discussion points or any of the manuscript when you read. But when you carefully look, so the risk of hemorrhage at the end of 36 hours was more in tenecteplase and almost attained statistical significance. Possibly if you had increased because there were a few patients who were removed from both these study arms, and maybe if the number had increased, I don't know if this would have attained statistical. So this is something that we need to keep in back of mind. So even authors do mention in their discussion that tenecteplase, there is numerical increase in the mortality, but it did not attain statistical significance. They only mention the safety endpoint that they saw at the end of 48 hours as saying 15 versus 13. But at 36 hours, there was more bleeding, as you saw in tenecteplase group. And they did compare the TRACE2 trial with ACT trial, because the only comparator we have for this tenecteplase versus alteplase is the ACT trial. So they found that the patients with minor disability or no disability patients were higher in TRACE2 as opposed to ACT, which means ACT had patients with higher disability. So possibly the effect size may have been undermined in TRACE2. So this is something very important for us to recognize. And NIHS's score, the median baseline also was lower, which means they have taken very stable patients, the Gordon variety sort of a patient. So ACT possibly had patients with higher modified Rankin score. So these are some of the limitations that one should look at, that they have carefully chosen their patients is what you could make out. And the endovascular thrombectomy, post-thrombolysis, they did take some of the patients, like 51 patients did undergo after thrombolysis as a salvage measure, only 4%. But in ACT trial, 25% of them had endovascular thrombectomy where they had large vessel thrombosis. And in ACT trial, they showed that tenecteplase was not superior in patients who underwent endovascular thrombectomy. But I will tell you about the other studies. So 505 patients in ACT trial had large vessel thrombosis who underwent endovascular thrombectomy, as opposed to only 4%, which is 51 patients in TRACE2 trial. So which tells us that possibly ACT trial had more sicker patients with large vessel thrombosis who needed this thrombectomy after thrombolysis. But there they found tenecteplase in that subgroup analysis was not superior to alteplase. And to this reference, we have this extend trial. This was an extend 2 trial which came in NEJM in 2018 by Australasian authors, where they specifically looked at patients with large vessel thrombosis needing thrombectomy. They compared tenecteplase versus alteplase, and they found the contrary. In ACT trial, it said that tenecteplase was non-superior, which is the latest. 2018 extend trial, which only looked at post-thrombectomy, they found tenecteplase was superior. The reperfusion that happened after endovascular thrombectomy, post-thrombolysis, tenecteplase was superior to alteplase in cohort of patients undergoing endovascular thrombectomy. This is very important, because all the tertiary referral centers would at some point of time, if they fulfill criteria, contemplate on endovascular thrombectomy. After this, there was a meta-analysis which came by the Greek authors, which was 4 randomized controlled trials, including 433 patients, where they again compared tenecteplase versus alteplase in large vessel thrombosis needing thrombectomy, where they found better recanalization and functional outcome with tenecteplase as compared. So you have 3 articles, extend trial and this meta-analysis, which tells tenecteplase is superior to alteplase in patients undergoing endovascular thrombectomy, but the ACT trial did not show the superiority of tenecteplase. So now coming to what is the optimal dosing of tenecteplase, because this is going to change, if at all, the practice amongst neurologists or in or our teams, whether tenecteplase becomes a standard of care. So they have looked at trials. So as you see, this was the TRACE1 trial. In TRACE1 trial, they've compared 4 doses, 0.1 mg per kg of tenecteplase, 0.25 mg per kg, and 0.32 mg, and they've compared with 0.9 mg of alteplase. And they found that any dose more than 0.25, 0.32 mg had a worse safety profile. And after this, there was a Norwegian trial, which was a NOR test 2 trial, which again compared the same dosages, 0.1 mg per kg versus 0.25 versus 0.4 mg and 0.9 mg, which is a NOR test trial, which came again in Lancet Neurology in 2022, where they showed symptomatic intracranial hemorrhage with worse clinical outcome happened at higher dose. So like in the Alteplase, where we had a 6 studies between Europe and the Asian, even here, there are 2 good studies comparing the dosage profile, and we can conclusively deduce that 0.25 mg per kg is a safe dose. Any dose higher than that has a worse outcomes. So ACT and TRACE2 both use 0.25 mg per kg of tenecteplase. So as I said, the limitations of the study is the clinicians were not masked to the randomization process as to which group the patient groups, although they were masked to the type of medications they get, but they could determine whether they go to group A or group B. So that could have potentially put in the bias. And one of the important limitations is they have excluded severe strokes or large vessel thrombosis who would obviously benefit from endovascular thrombectomy. That is where the whole debate is. In patients who undergo endovascular thrombectomy, whether tenecteplase is superior to alteplase as shown in the extent trial and the Greek meta-analysis, because the ACT trial did not show superiority of tenecteplase. So I think that is the contention that you can deduce from this study. So the future, the authors, we would possibly subscribe that it is worth exploring the time window from 4.5 hours to 24 hours. If the safety profile of these newer drugs is much better, is what has been proposed. So the conclusions, overall conclusions is in patients with stroke who are eligible for IV thrombolysis, but who are ineligible for endovascular thrombectomy, tenecteplase is non-inferior. But please bear in mind, numerically, the intracranial hemorrhage numbers were high in tenecteplase and almost attained statistical significance at the end of 36 hours in tenecteplase group. So would we trade off that bleed and consider it as an absolute safe? That is the point of discussion. That's where we find this trial to be debated, whether tenecteplase should become a standard of care or should we stick to alteplase. I think that is why we picked up this journal. And now India being very price sensitive, if you see tenecteplase was more pricey in China, but in India, in our pharmacy, tenecteplase 30 mg is good enough for even up to 100 kg because it is 0.25 mg per kg. The cost is 39,500 in our hospital. Alteplase 50 mg will not be enough because we had to, it's available as 50 mg and 20 mg vial. It costs 72,900 in my pharmacy, which I just checked in our pharmacy. So, which means alteplase appears to be more pricey in India as compared to tenecteplase, which is different in China. So my take is still, I'm not very convinced whether tenecteplase definitely is not superior, but in post-thrombectomy, whether we subscribe that tenecteplase is better is a question. And price-wise, tenecteplase seems to be a better promise. But I'm still concerned, my concerns remain about the hemorrhage, because the intracranial hemorrhage numerical numbers were high, mortality numerical numbers were high, and ICH is an important complication. So is it something that we are worried about? So we would love to hear from our expert neurologists and the panel. So thank you one and all. So I will stop share my screen and I'll hand over to Anirban to take on the proceedings.
Thank you, Pradeep. You have discussed very nicely this study, and this study has important informations because they would carry very important meanings. I mean to say, from the point of view that how we should go forward. We all know that tenecteplase is easy to use because it can be administered as a bolus over 1 minute, as against alteplase, which is used as an infusion over a period of 1 hour. So the convenience is definitely there. But what we are concerned most is about the bleeding, and number 2 is the sequelae, which obviously this study didn't find much because they had an MRS score of 0 to 1 at the 90 days. But most importantly, I will go on to Dr. Guru Prasad first, that since it is concerning a point that the eligibility criteria was that it included patients who were eligible for thrombolysis and excluded patients who were likely to have for mechanical thrombectomy. Now, does that mean that external validity of this study is extremely limited, because the results of this study would be only true for those patients who satisfy all these internal and this inclusion and exclusion criteria. And we know that a large number of patients who, even after receiving thrombolysis, are finally taken up for mechanical thrombectomy. Dr. Guru Prasad, please. Dr. Guru Prasad, am I audible?
Yeah. First of all, yeah. Yeah. Am I audible?
Yes, please go ahead.
Yeah. So first of all, thanks for having me on this webinar. Very interesting article Pradeep had presented. So the important to understand is, why is it tenecteplase making its presence felt? So one thing is, it's highly fibrin specific. It is 14-fold much more fibrin specific, and it has a longer half-life as compared to alteplase. That means the initial half-life is around 20 minutes as compared to 5 minutes, and that will remain in the system for long. Why is it important? I'll come to that. Regarding the question regarding whether only the select patients were subjected to thrombolysis, but that becomes very important. So why were not they think? Because this is patients, probably they're why they are not taken for mechanical thrombectomies. There is no large vessel occlusion. These are the patients who require only, because now the guidelines is that when we image them, we also do angiogram, either it's MR angiogram or CT angiogram. So we know what the vessels are, whether they need to be bridged following IV thrombolysis. So when you have a situation where they need to be gone for mechanical thrombectomy, the duration of where they will be taken for mechanical thrombectomy, whether there is a drip and ship type of thing where they need to be transported to other hospitals, that becomes a little bit biased. So this is much more select group where you can compare. I think that's a very good study where they compared patients who are not eligible for mechanical thrombectomy, because there's much more specific, and also the importance of the study becomes very vital, because you are comparing to alteplase head to head. None of the studies we have done that to which these numbers where alteplase was compared to thing, and where they have also included patients who are again subjected to mechanical thrombectomy. So this is a very select group. I feel that is actually the advantage of this study. And regarding the thing about safety profile, most of the tests, most of the trials, not test trial, the trial, the TRACE2 trial, if you see, when you say, Pradeep, that it is 36 hours, they are not symptomatic. So when you say increased bleeding risk, sometimes you can have perfusion hemorrhages. When you have reperfusion hemorrhages, that also be considered as hemorrhages. So that may not be symptomatic. We see it very commonly. They don't land up with extended ICU stay or lead to morbidity or mortality. So symptomatic hemorrhage, if you see the first two, if you want to show the slide, the first two groups are comparable between alteplase and tenecteplase. So there's no difference. Only when you see about within 36 hours, asymptomatic hemorrhage, maybe tenecteplase much more. Yeah. So if you see the symptomatic intracranial hemorrhage within 36 hours, there's no much difference, 2%, 2%. Only when you have parenchymal hematoma, we want to comment on this?
Yeah, no, I think it's fine. We can see that the numbers, although they appear to be significant, but they have not been found to be significant. So we won't comment on that. But I'm coming to another important point with Ajit. Ajit, we know that we have come across similar studies earlier, which have found that if tenecteplase is administered prior to an endovascular procedure, it probably has a better outcome. The flow is better. The vessels appear much brighter. So in this study, we have excluded that group of patients. We have not given any chance. So do you think that large vessel disease versus small and medium vessel disease is something one needs to consider while administering either of the two drugs?
Yeah, basically it's a contradictory finding. So with a little bit of deeper thinking, see, the TRACE2 trial that excluded the patients who are requiring mechanical thrombectomy. I would like to say that when you end to end, when you compare alteplase versus tenecteplase, and see when you compare alteplase versus altiplase versus tenecteplase. So when you do the comparison end to end, these patients, who are having this patient who has undergone mechanical thrombectomy excluded. See, the mechanical thrombectomy itself can have an impact in the functional outcome of the patient, can have a positive and negative impact. So when you exclude those patients who require a mechanical thrombectomy, so you can have a direct comparison, without, if you don't include them, then you can have again a head-to-head comparison is possible. But as Dr. Pradeep mentioned, the extended trial, whatever extended the trial in mechanical thrombectomy patient, the outcome is appear to be better. The study showed that the extended when it's given the extended trial for the patient who are undergoing mechanical thrombectomy, the outcome is better with tenecteplase rather than with altiplase.
Okay, I go on to again with Guru Prasad.
I want to add one point here. Add one point. Pradeep had mentioned about the Extend 1A trial. There, the recannulation rate in tenecteplase patients was double as compared to altiplase, even before the mechanical thrombectomy. It is not after mechanical thrombectomy. The functional outcome was better in tenecteplase group as compared to altiplase, but even before the mechanical thrombectomy was attempted, when they look at the initial check angio, there was double the rate of recannulation. So in that group also, where there is a large artery occlusion, tenecteplase is growing, has shown much more better recannulation. That's the reason why in the American, College of, Cardiology guidelines, now tenecteplase comes higher than altiplase in terms of patients requiring bridging therapy. When the patient is going for mechanical thrombectomy, tenecteplase is scored much more than altiplase now.
Sir, I would like to add.
That does that mean that in patients who are not undergoing any form of mechanical thrombectomy, in that case, one needs to be sure about whether it is a large vessel or middle vessel before one chooses tenecteplase?
Not necessarily, because what was the problem was all these trials and Indian trial also, they did within the first 3 hours. So we didn't have evidence for patients who came between 3 to 4.5 hours, which usually our type of hospitals get between 3 to 4.5 hours. So the guidelines from Indian DCGI was also only up to 3 hours, between 3 to 4.5 hours altiplase, up to 4.5 hours altiplase. This trial, what Dr. Pradeep has presented, now gives us a thing where they have head-to-head trials, non-inferior, so up to 4.5 hours. So that means you can choose. It all comes to the ease of use in terms of pricing. And one more correction I want to do is the cardiology, the department uses tenecteplase, which is a little higher dose. That comes in 30 milligrams, whereas the neurology, whatever the indication, what we use 0.25, it comes in 20 milligrams ampule. So the cost is lesser as compared to 30 milligrams. It's only 24 or 25 MRP. So in fact, it's 50% less as compared to altiplase. So it makes a significant difference in terms of costing also.
Sir,
So
I would like to
overall,
add few things.
Dr. Jaiprakash is there, Anirban.
Yeah. Jaiprakash,
Yeah,
be fast.
sir,
We get only 1 minute. Please be fast. Yes.
Yeah. Actually, I read 4 or 5 trials, that TNK S2B trial, Australian TNK trial, ATTEST trial, NORTEST, and Extend 1A TNK trial. So if you will look at the meta-analysis of all those things, the article that published by the American Heart Association in the journal Stroke, that is very good journal, and that meta-analysis of all those 5 randomized control trials, it clearly says that the strong evidence that tenecteplase is non-inferior to the altiplase for the treatment of acute ischemic tract. And one more article, that meta-analysis that published in the Journal of Neurology, which clearly says that the tenecteplase in that kind of patient is safe and effective as altiplase and might provide more benefit than altiplase. It was nice presentation by Pradeep Rangappa sir. And one thing he say, if we look at the Indian scenario, we have to see about the cost of what burden is going to the patient. So definitely there is no any doubt that, and if we'll go in deep, if we look at the study, one more thing I would like to add, because Pradeep Rangappa sir once showed that forest plot, if we'll see that hematoma, but if we will look at the confidence interval, it was 0.99 to 14.1. That is a wide confidence interval, and the p value was 059 something it was. So we should not look at only on hematoma. All the result, all the cost versus benefit we have to see, and definitely tenecteplase is a good choice. And even if you will ask to me that it will be a better choice. Yes, sir.
Yeah, thank you, Jayaprakash. Is any question from the audience, because we have already overshoot our time. So before any question, then we can.
So all the trials for so far has shown that only that it is non-inferior. So is it now that at this point of time people who are continuing the altiplase should continue the altiplase and continue tenecteplase should continue with the tenecteplase?
Absolutely. That's we see. The one thing is that conducting a superiority trial is difficult because of certain technical and regulatory reasons. So we are only left with non-inferiority, which is most commonly performed, and the equivalence. So only after some equivalence trial is performed, we can say with much more definite courage that that tenecteplase is better, if that be our reason to. But till that time, I think we have to maintain that those who are using altiplase may continue using altiplase, and those who are using tenecteplase, they may consider tenecteplase as a better choice in case their patients have to undergo mechanical thrombectomy at a later stage because of better canalization. And therefore, among the earlier studies, the one which is most commonly quoted is the one which was done by the paramedics when they used to administer tenecteplase in an emergency a kind of a scenario in the ambulance, and then shift the patient, and the patients underwent mechanical thrombectomy, and it was found that they have a better canalization rate.
So another advantage is that because you know that you are giving a bolus dose for tenecteplase, where you need to have an infusion as well. Then theoretically the chance of error is supposed to be more with an infusion. These kind of minor discussions are there because you are just giving us a bolus. So the chance of error are going to be less. At the same time, when you have any kind of a bleed or any adverse event happen, you won't be able to stop anything. Once it is given, it's given. That is the disadvantage of the thing.
One more advantage is because if it's longer half-life, because it stays in the system. Once the patient underwent mechanical thrombectomy, there can be a risk of distal embolization. So because tenecteplase is in the system for longer time, the distal thrombolysis also happens. So that's the reason why you have a better functional outcome thing. Earlier days when we use altiplase, after mechanical thrombectomy, we used to use intraarterial after doing a mechanical thrombectomy using a solitaire stent retrieval system. If there is a distal embolization, we used to inject a little bit of intraarterial altiplase. That's not required with tenecteplase because you have a better half-life.
Yeah.
One more thing, Dr. Guru Prasad, you have mentioned about its specificity for fibrin, and definitely that is. But another important thing is also there, that what can resist the plasminogen activator PA1 inhibitor. So that resistance is also more with tenecteplase. So therefore, this is also another advantage which tenecteplase was over altiplase.
Yeah.
So on that note, we can conclude today's journal club. I thank Dr. Pradeep Rangappa.
Final concluding remarks from all the panelists, and we can close it.
Okay. I request first
maybe
Dr.
10 seconds for
Ajit.
concluding remarks from
Yeah,
Guru
Dr.
Prasad.
Ajit, you get 10 seconds.
Yeah, so based on the current evidence, I agree that it is non-inferior at this point of time. But whether as Dr. Pradeep mentioned, the short trial, the phase 2 trial, there is some sort of concern regarding increased kind of a asymptomatic intracranial hematoma. Those kind of things are there. So at this point of time, probably I believe that persons who are continuing in our practice, we have been using tenecteplase for most of the strokes. But people who are using altiplase can continue to do altiplase, and people who are using tenecteplase can continue to use tenecteplase. That'll be my take on at this point of time.
Guru Prasad.
Dr. Guru Prasad. Guru Prasad.
Basically, I think important more than the comparison between altiplase and tenecteplase. Definitely, both are very good molecules and it can be continued to use depending on the use availability and thing. But important is, I think we need to spread the use of thrombolysis. I think it's still the reach is not at all there. It's only practiced in major cities and metros. I think tier 2 or tier 3 cities have to practice that. I think intensivist physicians can be flag bearers of this therapy, because it's very easy. You don't need so much of thing. For mechanical thrombectomy, for bridging, definitely nowadays the trials are now showing that the benefit can extend up to 6 hours, 24 hours, especially for posterior circulation basilar thrombosis. So but the patient should not lose the benefit of getting thrombolysis, either it is alteplase or tenecteplase. I want intensivists to take it forwards to extend the usage
Yeah,
of
thank
thrombolytic
you.
therapy.
Thank you, Dr. Guru Prasad.
Hmm.
Dr. Pradeep.
Yeah, so thank you, Anirban. So it's a very provocative study. I sort of concur with Jaiprakash, who made excellent comments about price sensitivity of our country. This coming at half the cost, and in patients with large vessel thrombosis, there are strong signals favoring tenecteplase. At least we have 3 good sort of trials. So maybe in that subgroup, definitely tenecteplase appears to be more beneficial. And Guru made a very valid point that intracranial hemorrhage asymptomatic, which may be other reasons. So that possibly has to be explored. So I would be little underwhelmed keeping that concern in mind. But tenecteplase appears to be the way to go for large vessel needing thrombectomy, and it appears non-inferior at this stage. But hemorrhage, we need to possibly keep seeing at the data how it is evolving. But tenecteplase is here to stay, and this is definitely going to change the practice, Anirban. And just for all
Thank
the
you.
audience, we will have this journal club every week. It will be on Friday. We had to do it this on Saturday because of logistics, but every Friday, this will be called as a quick journal review for only half an hour. And Anirban will remain the chief moderator for this with varying panelists. And Ajit will remain always in our panel, and we will have experts coming. So next week, I'll be possibly talking about the Clovers trial. Over to you, Anirban.
Thank you, Pradeep. So it was a lovely hearing from you. So till the time we get more evidences, we can say that the non-inferiority is proven and people can freely use either tenecteplase or alteplase in all acute ischemic thrombotic events. So till we hear from some more interesting articles come up in our next episode of Quick Journal Review, from all of us in the panel, Shabar Khayat, Shubh Ratri, and good night.
Thank you. Thank you all.
Thank you.